three well-known perspectives of the treatment of individuals with autism spectrum disorder, which include applied behavior analysis, or ABA, sensory integration therapy, sometimes referred to as SIT, and the medical model. ABA is often overlooked despite a wealth of research supporting the effectiveness of using behavioral principles to decrease maladaptive behaviors and increase functional and socially significant skills. Sensory integration therapy lacks empirical research, but is said to facilitate improvements in certain functional domains. The medical model believes that disorders stem from biological, genetic, or environmental defects and seeks to remediate these issues through prescription medication. In this debate, each person will have 2 minutes to present current research supporting the efficacy and use of their treatment model. Debaters will receive a verbal 10-second warning before time runs out. In the event of a debater running over time, I will say thank you to end their turn and move on to the next speaker. Following the presentation of research, each treatment model will be attacked by the opposition. Sensory integration will be attacked first, followed by the medical model, and ending with ABA. Debaters will receive 2 minutes for each attack and each rebuttal. We will begin Molly with ABA, followed by Michelle with sensory integration, and Corey with the medical model. Questions from the audience will be taken at the end, but anybody with questions throughout the debate is welcome to type them into the chat bar on the right, and I will read those later, or hold questions until after the formal debate has concluded. Debaters, please remember that this event is being recorded live and will be viewed by our classmates for this week's discussion board. Is everybody ready to begin? All right, we welcome the floor to applied behavior analysis.
When considering treatment options for individuals with autism, applied behavior analysis is recognized as being a safe and effective treatment method. According to Cooper, 2012, applied behavior analysis is the science in which tactics derived from the principles of behavior are applied systematically to improve the socially significant behavior, and experimentation is used to identify the variables responsible for the behavior change. One goal in applied behavior analysis is to improve the overall quality of life for those individuals with autism. In Dillenberger, 2013 state, all parents stated that ABA-based interventions had a positive impact on our children or child, with particular emphasis on reduced frustration and problem behaviors due to improved communication. ABA-based interventions impacted their child's life in 3 different areas: communication, behavior, and independence. In addition to this, all parents highlighted dynamic improvements in family life, particularly in terms of more manageable family outings and the skills that they learned in order to deal with problem behaviors in public. The overall purpose of ABA is to provide the individual with autism the tools to effectively communicate with others, appropriately manage their behaviors, and to be able to live a life of independence.
All right, thank you, applied behavior analysis. Sensory integration, you are invited to speak. Do we have sensory integration?
Okay. Can you hear me now? Okay. Sorry about that. In the most updated version of the Diagnostic and Statistical Manual, released in 2013, the American Psychiatric Association finally acknowledged hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment as a potential manifestation of restricted and repetitive patterns of behavior necessary for autism diagnosis. Despite the APA's only recent acknowledgement of the sensory aspect of individuals with autism, Jean Ayers and colleagues were exploring sensory needs and processes as early as the 1950s. Ayers produced many works on the subject of sensory integration therapy, touting it as even more effective than medication, rewards and punishment, and psychotherapy. In her work, Ayers used systematic and methodical efficacy of her interventions that are still used today by many occupational therapists and families to balance sensory systems, including tactile, proprioceptive, and vestibular senses. A major contribution of Ayer's work is the model known as the sensory integration therapy, which is based on the sensory integration theory. Sensory integration theory asserts that sensory integration is a neurobiological process that organizes sensation from one's own body and from the environment and makes it possible to use the body effectively within the environment. Despite the fact that the National Autism Center identified sensory integration as an unestablished intervention, it remains no secret that individuals with autism spectrum disorder present with unusual sensory needs and interests that need to be addressed methodically. Unfortunately, these needs and interests are largely being ignored by other practitioners working with individuals with autism, despite sensory integration therapy being one of the most requested services by parents of children with autism. Not only did Ayers produce a multitude of works supporting the efficacy of sensory integration therapy, a 2014 scientific study conducted by Schaaf and colleagues further confirmed that sensory integration therapy is responsible for the improvement in self-care and social activities, both of which are socially significant behaviors that contribute to improved quality of life for individuals with autism spectrum disorder.
All right, thank you, in sensory integration. Medical model, you may now present your current research.
For the medical model, Matson and colleagues, 2011, believe that currently the best established pharmacological agents are antipsychotics. Presently, only Risperdal and Abilify are the two antipsychotics approved by the Food and Drug Administration for the treatment of irritability in children and adolescents with autism. Warren and colleagues, 2011, also stated that Risperdal and Abilify demonstrate improvement in challenging behavior that includes emotional distress, aggression, hyperactivity, and self-injury. Families tend to go to medication if other therapies do not seem to be working. In 2015, Amen and colleagues conducted a study on the long-term effects of Risperdal. The study involved 84 participants that began taking Risperdal. 1 to 2 years after they began taking it, they checked in on 2/3 of the 84 participants to see the effects that the Risperdal had had. They concluded that social skills, which were rated on the Vineland Adaptive Behavior Scale, had improved. Parents also rated the Aberrant Behavior Checklist for irritability, and subscale scores were reduced at the follow-up of those taking Risperdal. Several other measures of maladaptive behavior, some related to socialization, showed improved functioning in association with Risperdal on the Aberrant Behavior Checklist or on the Modified Real-Life Rating Scale.
All right, thank you, debaters, for insight into each one of these perspectives. Now, each treatment model will be given 2 minutes to attack and rebuttal each other's findings. First, I invite ABA to attack sensory integration.
Michelle, you stated yourself that the National Autism Center has identified sensory integration as being an unestablished intervention. In an article by Lang in 2012, he states, given the lack of scientific evidence, it would seem alarming how often sensory integration therapy is reportedly delivered to individuals with ASD by agencies that are mandated to use evidence-based interventions. In fact, according to Lang, sensory integration therapy is among the most common of interventions delivered to children with ASD. Lang also reports that some researchers have argued that sensory integration therapy may inadvertently cause an increase in problem behaviors because sensory integration often provides access to enjoyable activities, attention from therapists, and break from work contingent upon the occurrence of problem behaviors. This practice may inadvertently reinforce or strengthen abnormal behavior in the long term and even mediate reductions in problem behaviors that are observed. Another major concern to address would be the fact that the first core ethical principle of doing no harm is not being followed. Why is such a treatment method even available when the National Autism Center has said themselves that sensory integration is an unestablished form of treatment?
All right, sensory integration, can you respond to these statements?
Sure. Molly, in response to the sensory integration therapy being among the most common interventions delivered to children with autism, that's because, according to Mandel and colleagues, 2005, Green and colleagues 2006, and Goen-Kukel and colleagues 2009, it's among the most frequently requested intervention by parents for their children with autism. These parents see the sensory needs of their children daily and also see that research is trending in a positive direction for the effectiveness of occupational therapy and sensory integration for children with autism. You're right in saying that there is research to support the idea that sensory integration therapy may inadvertently reinforce abnormal or problem behavior. In response to this, I would say that there's a lack of scientific evidence overall that states that sensory integration therapy is effective for decreasing maladaptive behaviors. While there are over 80 studies that have been published providing evidence in the effectiveness of sensory integration methods, many have methodological flaws and do not report treatment fidelity. The studies that do report treatment fidelity have minimally adhered to the fidelity principles outlined in sensory integration therapy. For this reason, several methods of scientific standardization of sensory integration therapy have been devised to include the sensory profile by Dunn, 1999, the sensory processing measure developed by Parham, Ecker, Miller, Kuanek, Henry, and Glennon in 2006, and various tools developed by Ayers to identify the sensory needs of individuals to be addressed in treatment. Goal attainment scaling is now also widely used in sensory integration therapy to determine whether interventions have been effective for supporting the individual in meeting their treatment goals. This is a basic picture of scientific inquiry, identification of the problem, needs-based intervention, and measurement of the intervention's efficacy using goal attainment scaling. Clearly, we need more research to prove our interventions are effective, but I anticipate that with the addition of scientific standardization for the field, more research will be published supporting sensory integration therapy as effective in the near future.
All right, thank you. Medical model, would you like to attack sensory integration therapy?
Yes. In your research, you stated that Ayers interventions are still used today to balance sensory systems. Well, a study done by Moore and colleagues in 2015 was completed to determine whether sensory integration treatments could reduce automatically maintained stereotypy. There were 5 individuals with autism that were prescribed sensory activities by an OT that competed with stereotypy for sensory integration treatments. They tested 2 types of sensory integration treatments, sensory diet and brushing with deep pressure therapy. The treatment effects were evaluated in an AB design, and neither the sensory diet alone, brushing and deep pressure alone, nor both treatments combined were effective interventions for stereotypy. As you can see, these results do not support the use of sensory integration as a treatment for stereotypy in autism. For example, from the study, there were 2 subjects with sensory diets that had the following results. They both received hourly access to sensory diet items alone for a total of 50 to 75 minutes per day for 4 to 6 weeks at a time, and despite this large amount of access to items, the sensory diet did not effectively reduce the stereotypy for either participant. I do not understand how occupational therapists think this is still an appropriate therapy for autism. You also previously stated that the National Autism Center identified sensory integration as an unestablished intervention. This clearly goes against the Ethical Code 2.09 about treatment and intervention efficacy. Clients have the right to an effective intervention, and you clearly stated that sensory integration is not an established intervention.
Sensory integration, you are welcome to rebuttal these claims.
Corey, as previously stated, despite the tireless work of Jean Ayers and other occupational therapists throughout the years, the field of sensory integration is lacking scientifically rigorous research to support our intervention's efficacy. However, in 2009, CENTL conducted a study assessing parents' views of complementary and alternative medicine treatments for their children with autism. Of the 44 parents participating in the study, 23 of them had tried sensory integration therapy. That's over half. 17 of these parents had been using sensory integration therapy for more than a year. Of the 23 parents who tried sensory integration for their child with autism, 48% of them reported great improvement in their child. 39% reported little improvement, and 9% reported no change as a result of sensory integration therapy. Of those parents interviewed who used sensory integration therapy, 43% reported positive changes in behavior. To me, that's a noteworthy percentage reporting treatments in this study. Reporting improvement. In fact, when compared to other complementary and alternative treatments in the study, sensory integration ranked in the top 3 interventions parents reported as most effective for positively improving behaviors. This to say, parents, at least parents included in this study, are identifying how effective sensory integration therapy can be for their children with autism.
Thank you, debaters. Next, we welcome applied behavior analysis to attack the medical model.
Corey, while some families may choose to take the medical route instead of using other therapies, we need to know whether or not this is a safe option. While you mentioned that Risperdal is one of 2 agents approved by the FDA, it does not mention the age groups that are included. According to Kent in 2013, Risperdal is the 2nd generation antipsychotic approved in the United States for the treatment of irritability in children and adolescents with autistic disorder. According to the core ethical principle, being faithful, professionals should be honest about the treatments that they provide and be educating those individuals so that they will be safe in using them. While Risperdal has been approved for children and adolescents, where is the evidence that Risperdal is approved for adults? And if it is not, at what age should we be concerned with stopping the use of Risperdal in children and adolescents?
Medical model, do you have a response?
I do. Molly, that is correct that Risperdal has only been approved for children and adolescents up to now. But according to Polite and McDougall in 2014, Risperdal was reported as an effective treatment for aggression in 3 adults with ASD in an uncontrolled study. Also, in a double-blind placebo-controlled investigation by McDougall and colleagues, 8 of 14 adults with ASD who presented with severe aggression responded to Risperdal. These are 2 studies right there that show some proof of Risperdal working for adults. Hopefully, there will be more done in the future, and it will be approved for adults by the FDA. We just need to have more research done of it with adults.
Sensory integration, you have the floor.
Supporters of the medical model encourage the use of medication to decrease the occurrence of sensory behaviors. However, Kent and colleagues 2013 and Malone and Waheed 2009 note that the use of medications comes with a host of potential side effects, including increased appetite, somnolence, drug-related dyskinesias, and metabolic problems, just to name a few. Some of these side effects require additional medications such as Geodon or antihistamines to reduce those side effects. Other side effects, such as the dyskinesias, may not be reversible at all. Even with the risk of these serious side effects, these drugs still may not be effective for decreasing sensory-seeking behaviors. The #1 core ethical principle for behavior analysts and most helping professions follows the Hippocratic Oath of do no harm. Sensory integration therapy comes with no side effects and is clearly safer than any medication. Can you respond to this?
I can. Yes, Michelle, there are some possible side effects with these medications, as there are possible side effects with the majority of medications people take every day. I'm sure we've all taken medicine, and you can read on the back that there are possible side effects. But when Amen and colleagues in 2015 conducted their study, they found out that even though there are side effects to Risperdal, the side effects become balanced out by the long-term social and behavioral benefits of Risperdal.
Great, thank you, debaters. Finally, we welcome the medical model to attack applied behavior analysis.
Molly, you stated that ABA is looking to improve the overall quality of life of people with ASD. But characteristically, research studies investigating the use of ABA seem to use single subject research, and this has many limitations. Some of them include the irreversibility of withdrawal designs, in which a change in the independent variable affects the dependent variable, the lack of ecological validity, so that the results you get cannot be easily generalized to a larger population. For example, individual differences could have a large impact on the effectiveness of the intervention. If you meet someone with autism, you've only met one person with autism. And another limitation is how visual analysis to interpret the findings may lead to individual interpretation. What I see may not be what you see. Graphs require large changes in behavior to see the effectiveness of the intervention. On the other hand, the medical model has a wide variety of articles used in controlled experimental designs, such as McDougall et al., which use a double-blind gold standard of research. Also, the Ethical Code 2.09 states that clients have the right to effective research that is scientifically accepted. ABA, how can you support the effectiveness of a therapy that lacks the generalization procedures inherent in experimental designs?
Okay,
Corey.
ABA, what is your rebuttal?
Corey, if you recall, Cooper, 2007, writes, Baer, Wolf, and Risley recommended that applied behavior analysis should be applied, behavioral, analytic, technological, conceptually systematic, effective, and capable of appropriate generalized outcomes. Cooper goes on to explain that a behavior change that generally has generality, if it lasts over time, appears in environments other than the interventions that initially produced it, was implemented, and or spreads to other behaviors not directly treated by the intervention. You also mentioned that individual differences and the effects of intervention by stating, if you've met someone with autism, you've only met one person with autism, which further supports the idea that results will not be easily generalized to the population the same way in all individuals. If it is, then we are doing something wrong. Our goal in ABA is to improve the overall quality of life for those with autism. However, it will not look the same from person to person. It is important to keep in mind that each person that we meet, with or without autism, will have a different learning method.
Sensory integration, you have the floor to attack ABA.
According to Lovaas 1987, to receive the most benefit from applied behavior analytic intervention, an individual needs to be exposed to ABA a minimum of 10 hours per week and will benefit most from the intervention at 40 hours per week. According to the BACB Code of Ethics, each client has the right to scientifically supported treatment. 10 to 40 hours per week is the scientifically based recommendation set forth by Lovaas in 1987 and continues to be the model today. That could be a lot of time for families to invest in one treatment for one child, especially if that child has siblings. Sensory integration therapy can be as simple as hugging or quickly massaging your child when they need deep pressure, and as easy as having them wear a weighted backpack or jump on the trampoline. Not only is it easy, it can also be fun for everyone involved. Is there a reason that ABA takes so much time, and is all of that time really necessary?
ABA, what is your rebuttal?
Michelle, you are correct when you stated that ABA requires a minimum of 10 hours a week, sometimes even 40. There's no denying that ABA is absolutely time-consuming. According to Cooper in 2007, the overall goal of science is to achieve a thorough understanding of the phenomena under study. If time was not taken to do this, we would not be getting the results that we are. Consider what Baer and colleagues reported as the 7 self-conscious guides of behavior analytic conduct. Number 7 stating, a behavior change has generality if it lasts over time, appears in environments other than the one in which intervention was initially produced, and or spreads to other behaviors not directly treated by the intervention. In order to do this, we definitely have to put forth the effort. McPhillamy and Dillenberger explain that the majority of parents highlighted that choosing an ABA-based intervention involved a lot of time and commitment. For example, attending workshops, conferences, trying to network with other parents that had children with ASD. And some of the articles go on to say that the vast majority of parents considered ABA to be very effective or effective? Well, you brought up ABA being time-consuming, especially with families that have other children. It is important to realize that similar to parents, siblings are often included in therapies as well. While therapists do spend a great deal of time in the homes, parents and families are there 24/7, so they see things that we don't. As I mentioned before, one of the 3 areas of ABA focuses on communication. While we are working on this with the individual, it is important to make sure that the parents and siblings are also working on the same things that we are. We want to stay consistent to encourage the same responses from the individual with autism. In addition to this, we also use the sibling when working on other difficulties that the individual with autism might have, such as social play skills. This process really does encourage family involvement in order to help the individual reach their highest potential. So while this process might seem time-consuming, we need to remember that all results will come with time. If you want to improve the overall quality of life for your child, it is something that you really should be willing to invest in.
Great, thank you, debaters. Dr. Dubar, do you have any questions before Erin summarizes and declares a winner?
Yes, actually I have a few, and whoever would like, I think, can answer them. One of the questions I had, since you guys are talking about sensory issues are part of the autism diagnosis, and if the research shows that sensory integration doesn't have the support to treat those issues, how would you guys suggest that individuals who are ABA in the field address sensory issues that children with autism have? So how would you suggest they address them if SI is not the way to go because of the lack of data? Anybody?
I think that other methods could also be included. If sensory integration, I know a lot of the kids that I work with like squeezes or things from their family. And with ABA, I know a lot of different things go through insurance for us as far as some of the kids have a swing in their home or a trampoline, or a lot of the parents do just provide squeezes. We teach the child to request squeezes through a form of communication, and then the parent is kind of implementing that even if they're not using direct sensory integration.
Okay.
There's also response interruption and redirection that's used pretty frequently in the field of applied behavior analysis, where if a child begins engaging in stereotypic behaviors, then the therapist is interrupting that response and then redirecting the child to another activity that is more socially appropriate than engaging in the sensory behaviors.
Yeah, those are great answers, guys. I think that it just gets tricky because there isn't a lot of data to support necessarily some of the SI work. But we all know that our kids have sensory issues, so we have to come up with ways to address them, even if sensory integration isn't the way that we always end up going, or often when you're the behavior analyst. Another question I had is, I'm just curious what people think about, as a behavior analyst, what you think is it appropriate for us as behavior analysts to be recommending medication for families, and how do people feel about that in terms of whether it's ethically appropriate, in terms of the codes that we've gone over and sort of sticking to our own expertise? What do people think about that?
Well, in my personal opinion, I think we should not recommend specific medications just because that is not our expertise. We are not a medical doctor. We don't know quite maybe the side effects that it'll cause. Also, maybe the other medications that the kid is on. They could be on something that we aren't aware of that they are taking at home, or even the side effects of 2 medications together, even if it's just cough medicine. I think it is very important in our ethical code to stay in that realm, just for the pure fact of we are in it for the child, in the advancement of the child, and we don't want to harm the child as another ethical code. So I think it's very important that we do not in my personal opinion, recommend medication or even bring it up if a parent comes to us and asks us, hey, I heard this works for aggression, what do you think? You can say, you know, I've read research about that, but I would definitely recommend you going to your medical doctor for that specific medication and that reference.
All right, if nobody else, I had two other questions, but I'll give you guys a break and just ask one of them. All right, so my question is more about sensory integration and really sort of alternative things to do. Since a lot of the research on sensory integration really talks about the fact that there's no data to support the effects of sensory integration, what kinds of data do you guys think we could take when we do need to address sensory issues to show the effect on those types of behaviors in the children we work with? Because I do think that's one of the big things with SI is how do you show that it works. So what data could we take?
So one of the things that we're doing in the clinic that I currently work for is we have a young man that I work with that seeks sensory input a lot. So what we're doing with him is he likes to tap his head. So what we're doing is every 30 minutes we are tapping him on the head, just non-contingently, to see if that helps to meet that sensory need that he has in a more kind of appropriate manner. And then we're all taking data on how often, that every 30 minutes that we do it, we're checking in saying that we've done it, and then we're looking at his behavior graphs to see if that is decreasing his self-injurious behavior that is doubling as stereotypy. He's tapping himself on the head. It's also serving the function of stereotypy, but it's also self-injurious because he's doing it pretty hard. So to answer your question, the data that we could collect is data associated with the intervention that we're doing, and then look at the behavior graph and see if it's effective for reducing the behaviors that we're trying to reduce or improving the behaviors that we're trying to improve.
Thank you. That's helpful because I do think, you know, sort of regardless of the research that exists, we all know if you're working with children that the majority of them have some sort of sensory seeking behavior. It really just depends on how we decide to define that behavior, what we decide to use it as an intervention, and sort of how we decide to collect that data. So regardless of whether we use a sensory integration approach or not, those are things that we have to address. And as a behavior analyst, sometimes I think you find yourself having to address all sorts of behaviors you weren't expecting and things that maybe you didn't exactly learn how to deal with that behavior. So it's just good to be able to think through how to manage those situations. So that's enough for questions. I won't ask you guys anymore. You're doing a really nice job.
All right, well, thank you for your questions. Erin, you have the floor to summarize our debate and declare a winner.
Thank you. I would like to thank everyone. Michelle, Molly, and Corey, you did a wonderful job debating your arguments and pointing out certain ethical codes. You also had very valid points to your specific therapy. And I'd also like to note that you did a wonderful job having to rebuttal against those who may not have agreed with your specific therapy. Now, though you all made excellent points to why ABA, sensory integration, medical model, would be the most effective treatment regarding an individual with autism disorder, there are a few in each argument in rebuttal that I would like to touch on. This will be very brief, by the way. Sensory integration, when you talked about Jean Ayres and how she produced many works within the subject of sensory integration and how it is more effective than medication, rewards, psychotherapy, and punishment, I would like to say that is a strong point to present on. Medication is certainly helpful, but is not always the most effective, and with the side effects, it just may not be worth it. A second point that I thought was strong was mentioning the article conducted by Schaff and colleagues. This article stated that sensory integration therapy is responsible for improvements in self-care and social activities, which is something that most parents state that they want for their child, and it can open up to doors for other improvements and advances in their life. For the medical model, you had a couple very strong points, and I would like to touch on those as well. Mentioning the article by Polite and McDougall stating that the antipsychotics are currently the most worthwhile intervention available for treating irritability and other disruptive behaviors in children with autism. With this type of treatment, you can improve on their developmental progress, which is something you also noted in your article. And another strong point is that you included the effective treatment for adults with autism. I thought that was something that is rarely talked about, so it was great that you touched on a little of what these drugs can do outside of the children. For the strong points of ABA, ABA has many goals for children in this therapy, and one important goal is the quality of life of the children as well as their families. The McPhillamy and Dillenberger article you talked about quoted parents that used ABA-based interventions, stating ABA had a positive impact on their child. And the 3 categories that it impacted them the most were communication, behavior, and independence. I think these are 3 very important categories for children with autism, not only for them personally, but their families as well. I could go on about how important these skills are and what big stepping stones they are for children, but I will move on to your second strong point. Now I'm going to contradict myself with this one later. I thought you made an excellent point during your rebuttal, stating that it is time-consuming, but most things that last are. You don't want you want these types of accomplishments to last. Sorry. I quoted what you said within your rebuttal. While this process may be time-consuming, the results will come. If you want to improve the overall quality of life of your child and your family, time is something you really should be willing to invest in. With that being said, you all had very great arguments and valued arguments, but of course in any debate there are weak points as well, and I will state one weak point for each therapy. So for sensory integration, I will start. I think a huge weak point, and you even stated in your argument, is the lack of evidence and the unestablished intervention. Some articles even stated they see improvements in the child, and SI is one of the top therapies chosen for children with autism. Though those things are true, this doesn't change that SI is the type of treatment that has no support for their effectiveness, and I quote the National Standard Project under the unestablished treatments, that parents should not use these programs given the lack of their support for their effectiveness. I also briefly mentioned in the attack on SI from ABA, some increases were found in problem behavior and it inadvertently reinforced and strengthened abnormal behavior in the long term, which is something that we would like to see decrease instead of increase. Medical model. I think it's great that some of these drugs improve irritability and aggression with children and adults, but medication is sometimes not always what you want to give such a small child. I think Michelle made an excellent point, stating that the use of medications come with a host of potential side effects and sometimes runs the risk of even serious side effects. I think this is a weak point for the medical model, and you also have to think if there's any other therapy interventions being ran at the same time of these medications. ABA, now here's where I contradict myself from my earlier statement. I think, though it is a strong point, it's also a weak point that it takes time for the interventions to work. To show development for the child, it also takes time, and it may take quite some time for children to learn to mand or tack for items, comprehend social skills, which is important, and gain independence. It's a slow and steady process, and when you are dealing with some more serious behaviors, waiting isn't something you are willing to do. With wrapping up the debate and having you all present very strong arguments for each individual model, the one strongest argument I would have to say was ABA. I think Molly presented very strong arguments and provided great rebuttals, proving to us why ABA is the winner of this debate. Thank you, everyone, and I hope you enjoyed.